Hello, everybody. Welcome to the EIDA Insight Hour. Just going to give it a few minutes before we start to let people trickle in. Welcome, everybody. Thank you for joining EIDA's Insight Hour today. Just going to give it a few more seconds for people to come in. I can see the numbers climbing up. Okay, I think we will start. Thanks everybody so much for joining. We are in the EIDA Insight Hour addressing perpetrators in the workplace. I'm Aisha Fordham, the Head of Membership and Engagement at EIDA. We are a network of now around 2,000 employer members from across the UK, from different size organisations and different sectors, with our mission being to support employers to put an effective response in place to support their employees who might be impacted by domestic abuse. Work could be someone's only safe place, and it's really important for employers to create a culture within their organisation where people feel physically and psychologically safe to talk about domestic abuse and get that support from their employer. So today, as mentioned, we're going to be talking about addressing perpetrators in the workplace. This is an incredibly challenging topic, and it's an area that's coming up more and more amongst our members in terms of something they want to build out and improve their response and the offering they have in the workplace. So just a few points on housekeeping before we hand over to the speakers to introduce themselves. We have a lot of content to get through today, really interesting content, and we may not have time for questions at the end, but please do continue to put questions in the Q&A box throughout the session, and if we have time, we will answer some at the end. If we don't have time, we will try and include some of the answers within the written summary, and I can also connect you with the speakers if needed. We have the chat function, so I can see people writing in the chat function now. Please introduce yourselves and post comments to each other throughout the session in the chat bar, but please avoid putting any questions aimed at the speakers in the chat bar as they can get missed. So please do use the Q&A box for questions. We encourage people to post on LinkedIn, so please follow and tag EIDA. And as ever, please do be mindful of the impacts on others and what you choose to say on social media. So we will be recording this session, which will help us to prepare the summary of the key points, and then we will share that written summary out within the EIDA newsletter, which you can sign up to on our website if you don't already receive it. We appreciate that domestic abuse is a challenging topic, so please do look after yourselves and step away from the webinar if you need to, or seek support afterwards. We have the directory of support services available on the EIDA website, which is being posted in the chat bar now, so please find your way to that website if needed. So the focus of today's Insight Hour is looking at addressing perpetrators in the workplace, what employers can do to respond, and how this can be done through a victim survivor lens. So we're joined by four brilliant speakers who are all really supportive individuals of EIDA. So I really thank you for your time today and for sharing your expertise. If I could just ask the speakers to put their cameras on, and I'm going to ask them all to introduce themselves before we get into the presentations. So Sandy, coming to you first, could you please introduce yourself?
Hiya, I'm Dr. Sandy Deanser and I'm a researcher at Bristol University. Nice to be here.
Thanks, Sandy. Rebecca?
Hi, everyone. I'm Rebecca Faggy, and I'm the head of Make a Change at Respect.
Thank you, Rebecca. Emma?
Hi, I'm Emma Stacey, and I am Group Health, Wellbeing and Personal Safety Lead at Life Banking Group.
Emma and Mina.
Hi, everybody. My name is Mina Kumari. I'm the director and founder of Hope Training and Leadership, CIC, Community Interest.
Amazing. Thank you so much. So really wonderful, brilliant to have you all here. And we're going to get straight into the presentation. So I'm going to, first of all, hand over to Sandy to present for 15 minutes on the research that she's done. Thank you, Sandy.
Thank you. Just waiting for my slides to come up. Oh, thanks. So hi everyone. As I said, I'm Sandy Deanser. I'm a researcher at the University of Bristol, and my work focuses on the intersection of violence, abuse, and health. Today I'm going to present findings from the Pressure study, which was about healthcare professionals' own experiences of domestic abuse. And I'm just focusing today on the findings where the perpetrator was also a healthcare professional. And one of the things I'd like to do today is dispel myths that doctors don't perpetrate abuse. And I'd also like to highlight what happens when perpetrators have power through their employment status, through their professional status. So back in 2021, with colleagues, I led something called a meta-analysis, where we pulled together all the research about healthcare professionals and domestic abuse. And we found that 31% of healthcare professionals have lifetime experience, which is really high. And it was 42% just looking at the female health professionals. 5 studies within this review showed that perpetrators were sometimes healthcare professionals as well. And one of these studies was by a GP called Emily Donovan. And in her study, survivors said perpetrators who were also doctors falsely diagnosed them with mental health problems, and perpetrators received better treatment by other professionals because of their doctor status, linking to this myth about who does and who doesn't perpetrate abuse. So 2 quotations from survivors that Emily Donovan interviewed are here. So one of them I'll just shorten. He applied for an order to try and get the children returned to him, saying I'd probably become psychotic and that's why I'd left him. And then another quotation, established GPs and consultants were standing up in court saying he couldn't have done any of these things, how great he is and what a wonderful father he is. In another study, a practitioner who'd supported a survivor whose perpetrator was a doctor he'd said, do you know there's over 40 ways to kill a woman and make it look like she died from natural causes? That's power and control at a whole new level in the hands of someone very educated and sophisticated. And it's this power and control I want to talk about today. As a caveat, our study didn't set out to look at healthcare professional perpetrators. And in fact, there is no specific research on this topic, but I'll present what we do know. There is a little bit of policy and guidance on this topic. So specifically, NHS employers has guidance for what hospitals should include in their staff domestic abuse policies. And it has a short section on perpetrators who are employees. And people working in other sectors might want to have a look at this template and see if it's useful for their own, local sector. But it says that NHS employers should take formal action if perpetrators incur DA-related criminal convictions and notify the professional registration body where appropriate. The employer should minimise the potential for the perpetrator to use their position or resources to find information about the survivor. It should take disciplinary action if they've used organisational time, property or resources to abuse. It should require orders like non-molestation and occupational orders to be declared. And it might consider a change of role if the perpetrator's job involves contact with children or vulnerable adults. The guidance also says that policies should address support options if the perpetrator wants to change their behaviour. So policies should include local perpetrator programme contact details. And it should also address the situation where perpetrator and survivor are both employees of the organisation. The guidance is vague on this last point, and actually it mentions relocating the survivor as an option, but not the perpetrator, and that mirrors the wider tendency to move survivors into refuge rather than moving perpetrators. So turning now to the Pressure study, the study involved a survey and follow-up interviews, and just looking at the subset where the perpetrator was also a healthcare professional, there were 27 healthcare professional survivors who experienced domestic abuse from 29 healthcare professional perpetrators. So 2 of these survivors had more than one perpetrator, like a partner and a father-in-law, who were healthcare professionals. It was mostly men abusing female partners, although we had a woman who experienced domestic abuse from her aunt and a man who experienced domestic abuse from a male partner. They didn't want to be interviewed, so we've got limited detail on their cases, but it does highlight that women can be victims, women can be abusers, sorry, men can be victims, and not all domestic abuse is intimate partner violence. All domestic abuse types were reported, including rape, and economic abuse was really common. And these boxes you don't have to read, but I just want to highlight that gender roles coupled with professional status, professional identity, reputation, and persona were all really key concepts in the analysis and in the abuse. So I'm writing an academic paper about these findings, which you'll be able to read in due course. But there are four main themes which I'll summarize for you today. The first one is power conferred by professional status and gender roles shaped domestic abuse. So I'll go through all of these, so I'll talk about that one first. So regarding that first theme, survivors' reports suggested that perpetrators' professional roles and the status and the power that that their roles conferred facilitated their use of domestic abuse and heightened its impact. And interwoven with all of this was the use of power that came from their male gender role. So what I mean by this is that these perpetrators had really easy ways to explain away their abuse. One example is that it's really common for doctors and surgeons to move around on different placements in their careers with opportunities to work abroad. And we had a couple of survivors say that despite them also being doctors, these perpetrators made big and sudden decisions about where they would live without discussion or negotiation, and essentially isolated that survivor from support. And these decisions sometimes coincided with the survivor being on maternity leave or working part-time because of childcare. Survivors had less of a voice and less of a so-called right to decide where they would live because they weren't working or they were working part-time. Now, it's really common in the NHS for women to take leave, maternity leave, and to drop to part-time hours, partially because it's more economically viable for them to do so rather than for their partner to take parental leave or their partner to take part-time hours once a child is born. There's a 10% gender pay gap in the NHS, and men are disproportionately employed in higher paid roles. So you can see how sexism embedded in organisations, employing organisations, really lays the groundwork for domestic abuse to happen. We also found that perpetrators discredited survivors to others. They falsely diagnosed them with mental health conditions, like Emily Donovan found, as insiders, as kind of employees of the same work, of the same employer. They knew exactly how to threaten survivors. They threatened to report them to their professional regulator, their employer, and their colleagues for being mentally unwell. One perpetrator reportedly threatened to tell a survivor's colleagues that she had previously whistleblown on an unrelated issue, which he could do because they worked together. And in some cases, these weren't just threats, perpetrators did report them. And the second theme here is about persona. So these perpetrators, it really shows that this abuse was choice-based, because these perpetrators curated a persona so that they could enjoy the privileges of being seen as good men. They were all men in the interviews in public, while getting away with abuse in private. And working in these caring professions with good jobs and being good with patients helped them to cultivate this persona, helped them to convince others that the persona was their real character. And what happened was that survivors thought, well, no one's going to believe me if I tell them about what's happening now. So these personas served to preemptively discredit survivors. But this sense of entitlement was also prominent. So a few survivors reported that perpetrators didn't always hide their abusive behaviours. They didn't always curate this persona. So, for example, one boasted to his peers about domestic abuse, and these peers were complicit. They didn't call out his behaviours as unacceptable. And they had a sense of inculpability or invincibility, a sense that the rules don't apply to me. One survivor said that for surgeons in particular, they're seen as gods, their power is taken for granted, they're not challenged by others in the healthcare hierarchy, and that allows these harmful behaviours to flourish. So the third theme was about constricted support for healthcare professional survivors. So because here we're talking about a survivor and a perpetrator, they're both healthcare professionals, the survivor's own GP, the survivor's colleagues, and services to which she might refer her patients, they were all part of the same healthcare network. And this massively constrained the support that the survivor had available. So usually somebody who experiences domestic abuse will tell their GP before they tell any other professional. But here survivors couldn't do that. They worried that by telling their own GP or telling a colleague that they had, that they kind of trusted at work, that word might get back around to the perpetrator who would then retaliate. They worried that word would get around through formal information sharing processes that would get out of control for them, or through gossip, because for some of them, they didn't trust their colleagues, they didn't trust their GP. One said that her GP was a friend of the abuser. So you can see how when the perpetrator is a colleague, actually they can create an almost like a spider's web that traps the survivor and makes it impossible for them to talk to anybody about the abuse and get help. And then the last theme is about injustice and institutional betrayal. So institutional betrayal is when an institution that a person trusts, or maybe they don't trust the institution, but they need their support, causes harm. I won't go into detail here about family court or criminal justice, but I'll just talk about the survivors being let down by their employers and regulators. So when criminal justice didn't work out, or when family court was a nightmare, which it often was, survivors often hoped that the employer would like instigate sanctions against the perpetrator, or would do something that could feel like a form of justice. But this didn't happen. So survivors were constantly let down by their employers and by their regulators. They said that employers often relied on criminal convictions as evidence of wrongdoing, even though criminal convictions for domestic abuse and sexual violence are really difficult to attain. The survivors also said that powerful individuals within organisations had really harmful beliefs about domestic abuse, like survivors sometimes lie, or it's a personal issue. And that then leads to a lack of robust organisational policy. So survivors felt that there was no justice option, and actually trying to get justice only served to re-traumatise them and risk retaliation from perpetrators. So the key recommendations from this work is that, so what I would say is that any domestic abuse training for healthcare professionals should clearly acknowledge that healthcare professionals might be survivors or perpetrators, and this is the same in any organisation really. We need to dispel this myth that some people, because they do a nice, helpful job in society, they couldn't possibly be a domestic abuse perpetrator. That is nonsense. And we need to include in all training that there isn't anything like an us and them. You're the helpers, they're the victims, your job is to help them. Anybody in that training room might be a survivor. Anybody in that training room might be a perpetrator. And so any training also should signpost perpetrators who are wishing to change their own abusive behaviour. As I just said as well, some of these perpetrators boasted about the abuse. Sometimes they used harmful behaviours in the workplace, and because they're a surgeon or a consultant, no one questions them. Workplaces and medical schools need active bystander training to equip individuals to name behaviour as unacceptable, and bystander training alone won't work. We also need robust accountability systems, supportive leadership, and clear communications about zero tolerance policies. And what else? So NHS employers guidance, the fact that it exists is excellent, but it needs evaluation to establish whether it's workable and whether it's actually being implemented. So from what survivors said, there wasn't a sense of justice through their employer. The employer kind of just defaulted to, well, they haven't been found guilty of anything. We can't do anything. So that really means that we need to question whether this guidance that NHS employers has is workable. And if not, why not? What support do organisations need to implement it? So if any of you work in other organisations that want to implement a policy, design a policy, but then also consider, is it actually going to work in practice? Regulators, this is very healthcare specific. Regulators like the GMC and NMC need to have clear guidance for survivors on what to do if a perpetrator is threatening to make a vexatious or malicious complaint. And we also need deeper culture change. We can't, domestic abuse happens, I think, because of sexism that exists more broadly. So we need to look at how to dismantle sexism in organisations. So things like regular gender pay reviews to close the gender pay gap and economically empower women. We need to do all of that sort of stuff if we also want to address domestic abuse. So that's my last slide, so I'll stop there. Thank you very much.
Thank you so much, Sandy. That was really, really interesting, and I definitely agree with all of that. And the deeper culture change is needed within organisations to really enable people to feel like they have that trust and confidence within their employer to speak out about the abuse they're going through. So, yeah, I mean, everything that you spoke about there is really interesting and definitely applies across other sectors as well. The four themes and the recommendations, particularly those sectors who have those power imbalances and figures who hold that authoritative and trustful position within society, and using that position to continue abusing the victim survivor. So that's brilliant. Thank you so much. I'm now going to hand over to Rebecca at Respect, who's going to talk through what they do as an organisation and a healthcare pilot project that they're working on. Thank you, Rebecca.
Thank you, Aisha. So let me get my slides. Right, it's fantastic to be here with you all. There we go. Hopefully you can see that. So I'm Rebecca from Respect, which is a national UK charity dedicated to stopping perpetrators of domestic abuse. And I also work for the Make a Change project, which is an early intervention response model that we deliver in a handful of communities in England. And it includes direct behaviour change work with perpetrators, associated support for survivors, and wider work with the community. So that might be professional agencies and organizations, as well as the general public. And ways that we can access that is through employers. So we're looking to build our relationships and intervention offer with employers in our local communities. So I'm going to start by talking today a bit about the work that we do at Respect and dive into what behaviour change work is all about. And then I will lead on to the health project. And so the two really go, they complement each other in terms of the work that we are trying to achieve in our communities. So at Respect, we understand that domestic abuse is linked to wider structures of oppression and inequality in our society. And domestic abuse, we know, occurs at that individual level between intimate partners. So that might be a current or former partner, and it can occur within family members as well. But we know that these choices that are made on an individual level as well, and will be based on individual experiences, can't be separated from what we are experiencing in the wider society and what's going on in the communities that we live in. So addressing this issue of domestic abuse, and particularly the perpetration of it, has to have a systemic approach. So that we look at both the individual and the community that they're based within, but we look at the institutions and the systems in our society and our wider culture. And as Sandy talked about in terms of the role of the employer, what can we be doing within our workforces and our work environments to be promoting positive cultures around domestic abuse in terms of help seeking for people using harm and holding them to account. And I'm going to talk to you a bit about some of the concepts that we use on our behaviour change programs that hopefully will give you an insight, and you can take inspiration from this in terms of looking at your own approach that you might be looking to develop within your organisations. So for those of you who are unfamiliar with Respect, hopefully you know about us. We are working towards a world that is free from domestic abuse, where everybody who is using harmful behaviors has an opportunity to access help and is also encouraged to be stopped and held to account. And that there's the message clearly in our society and within our culture that it's not okay to control, to harm, or to cause fear to a loved one, such as a partner, ex-partner, or family member. We work with a wide range of stakeholders to deliver our mission and our vision. We offer a membership program where we have a range of associates. We offer two types of membership. One is to associate members, which could be any organization or individual professionals that want to connect with our work and are part of this, share the vision and the mission to bring an end to domestic abuse. We also have an accredited members offer, which are for those domestic abuse services that are out there delivering direct services to perpetrators. So at last count, we have just under 1,000 members, which represent individuals and organizations as well. So this is available to anybody here today who might be interested, and you can find out more from our website. But hopefully you likely know about us through the Respect phone line we offer for people who are causing harm, and the male victims helpline, which we offer alongside that. And it's one port of call, and there's skilled practitioners there who are able to field those calls regardless of who's calling in. And I'll leave contact details at the end as well with my slides. So just to tell you a bit about perpetrator programs, and you've heard about, I'm sure you would have heard about these programs, and hopefully you're encouraging people to access them where they're available in your local areas. And of course, the National Domestic Violence Helpline is a 24-hour is a helpline that can help you access where you can access support in your local areas if you're not sure if you have one in your area. But how behavior change programs came about, they started appearing in the late 90s, early 2000s. And at Respect, we formed to provide a steer towards these local programs that were popping up across the country and setting up alongside services for survivors. So they've always operated separately, usually. And what the aim of our mission was at that time was to help these local services to create a network and to promote safe and effective provision across the country. And we developed the Respect Standard in 2014, which you have a link to here. And it's an extensive document that goes through how an organization would go about getting an accreditation standard. And this is like any other industry standard, which you might look at, getting for customer service or for data protection. There'll be a set of areas and indicators that reflect what good practice looks like. And following on from that, the Home Office developed their own standard as well. And the standard was very much influenced by the Respect Standard. Ours goes into a significant more detail, and we also offer an accreditation process alongside that. But both are there and in existence to offer a benchmark for what safe and effective practice looks like in perpetrator provision. And we both adhere to two key core principles. So it's not only backed up by what research and evidence shows works in this area, but it's also about looking at key elements that must be there for ensuring that safe and effective program delivery. So this will include things like having a skilled workforce, ensuring that risk and safety is incorporated through risk assessment and case management support. There'll also be a component about connecting to somebody's identity and diversity and ensuring that we're offering fit for purpose services to people based on protected characteristics, for example. Underpinning both of those standards is these principles of safety first and do no harm. And what we mean by safety first is that the primary purpose of any behavior change work with a perpetrator is to increase the safety of the person experiencing harm. So we would say the survivor in that instance, or the victim is another term. And that would be the partner, the ex-partner, or the family member, as the definition of domestic abuse recognizes as survivor or victim. And this includes children as well. So the priority aim as well should be to cause no further harm. And that is really important because we want perpetrators to take accountability, but not at the expense that it's going to increase the risk of harm to that survivor. So how we ensure that is that we offer, it's very important, and both standards recognize that engaging and including the victim or the survivor in this work is essential. So at Respect, our accredited program members will be looking to get the contact details of survivors from the perpetrator and making contact with them to check that it's safe to go ahead with this. And they'd be offered separate independent support along the perpetrator undertaking behavior change work. And so that's the ideal. And we would exhaust all efforts to try to make contact and find out what we could from anybody connected to that survivor, that this is safe to go ahead with. And so what would happen is you'd have a perpetrator often will be progressing through the program, and they'll have their own practitioners that are delivering the service, and there'll be a separate practitioner or worker that will be there for the survivor. And each will be in contact, and they'll be coming back through the service, and those practitioners will be connecting with each other. They'll be undertaking and monitoring for risk and safety needs. They'll be looking at, what accounts are being shared by both and ensuring that there is no further harm caused to that survivor. So there'll be frequent contact, lots of information sharing going, and consideration around the safeguarding needs for any of those individuals, including children. So it's really skilled work that's happening, and it's really important that confidentiality is also preserved so that anything that that survivor is saying isn't going to be alerted to the perpetrator that could indicate that that person could cause further harm. So that would be the core components of this work. And just to say that the standards both recognize two types of intervention. So one is the classic kind of behavior change programs, which we call domestic abuse perpetrator programs. They're typically delivered in 20 or 30 session as blocks of a program and in group formats. And as mentioned earlier, we recognize that domestic abuse is gendered, and most of the groups that we deliver are for cisgender heterosexual men. And anybody that would be outside of that definition, so let's say if it's somebody from an LGBT plus community or a particular ethnicity, or if it's a woman using force, there would be an assessment process to identify what's going on, and there could be an offer of one-to-one support instead of a group, which wouldn't be safe for them to potentially be part of that. And then there's other types of intervention. The other main type of intervention is what we call the intensive case management support. So these are for people that are using harmful behaviors that are high risk, high harm. They might be well known to the local services in their community for frequent police call outs, and maybe not necessarily engaging with any of the support services that are around them. And this program is intended to disrupt those high risk, high harm perpetrator behaviors. And so there'll be an emphasis on working in a multi-agency context with the police, with probation, with social services, and any other professional that person might be in connection with, to look at how they can work together to reduce the risk of harm to survivors and hold that person to account. The main aims of the perpetrator programs for both types are about increasing survivor safety. So they're the primary beneficiary, and we want to see that their safety is increasing and that they're increasing their space for action. And I'll tell you a bit more about that on another slide. And for perpetrators, this is about reducing their abuse, but also increasing their ownership so that they recognize what they're doing as abuse, and they are committed to making a change and choosing non-abusive behaviors. We also want to see that they recognize the harmful impact it's having on survivors, including children, and developing insights into, what is going on there, and how they might be framing their relationships and their partners as unequal members in that relationship, and how that is resulting in them causing them harm. We want to train and provide materials and resources that help them to recognize different ways of being, so that they're not being harmful. So that might relate to any emotional regulation techniques. And we also want them to see their partner as equals. I'm going to move on to the next slide. So one of the main key concepts that we use and it is the power and control wheel. So hopefully people here are familiar with this tool and you will have seen it before. And if not, this is available online, and there's been multiple types of other wheels adapted for different types of protected characteristic, identity factors, and but where it comes from is it's a bedrock approach that often underpins most of the behavior change programs that Respect will be accrediting, if not all. And it comes from the Duluth model, which is part of the coordinated community response approach, which includes an element of behavior change work for perpetrators, and it also offers support for survivors. And Ellen Pence, who founded this program, created these wheels based on consultation with multiple survivors to try to get a sense of how they were what they were experiencing from their perpetrator. So it's become a way of articulating what was happening to them. And what you see in the power and control wheel are the spokes, which are representing the tactics that perpetrators tend to use to gain power and control. And by using those tactics, that's what's happening. They're gaining power and control. And so this is where often the tactics represent non-physical types of abuse, which survivors can say is quite tricky to identify is happening to them. So this tool became also a naming function for helping survivors recognize what was going on. And in the equality wheel, kind of that's the flip side. So if you use the tactics there, which include like respect, trust, mutual kind of, negotiating, knowing that you may not always agree, but giving that person space to express an opinion and have a difference of opinion. Perhaps, that there'll be a range of different types of behaviors playing out, but it's founded on those tactics result in an equal, or what we might call a healthy relationship. And so what we want to draw perpetrators into is this appeal of leaning towards the equality wheel, because what we find is that most perpetrators will agree that the spokes and the tactics in that equality wheel is what they want for their relationship. So we're trying to bring awareness to how the behaviors they're using in the power and control wheel is working against that, and trying to build their motivation to create the change. Another key concept that we use is the space for action concept, which was developed by Liz Kelly at Metropolitan University. And this was in connection to understanding that coercive control narrows a person's space for action when they're experiencing that. And this is defined simply as a person's space to be, to think, to do in their day-to-day. So their everyday choices of how they want to live and what they want to do with their lives, and decisions they want to make in relation to people they want to see in the day, how they want to dress, what they want to eat, where they want to work, how they want to spend their time. And, many survivors that I've worked with have said to me over the years that their perpetrator became the center of their world for all the wrong reasons. And it became about either complying or resisting to them. And they've completely lost sight of their own needs, their independence, their autonomy, their choices in that relationship. And so, again, it's wanting to draw attention to perpetrators that this is the impact it's having on your survivor, and this is harmful for both of you. This next slide I'm going to introduce you to is, again, another way that perpetrator program facilitators will be looking to understand a perpetrator's account when they come into a program. And it's useful for employers to think of this as well, because you might be working with just the person using harm. You might be working with both the person using harm and the survivor. You might not have any connection at all to the survivor. So even if the survivor is not in physical proximity to you, can you keep that person in mind when you're thinking about how you respond to the perpetrator? And often what will happen is you'll get perpetrators coming to a group and you'll get their version of their story. But if you ask the survivor what was going on, you'd probably get a completely different account. And that's why this survivor-centered work this is what we mean by it, and this is why it's so important. So, for example, a perpetrator might come into a program and say their partner is always arguing with them, they're always getting on their case, they can't be trusted. If they didn't nag so much, they wouldn't have lost it. They're having stress at work. It was a really hard week for them. Oh, I've never hit the person, I've never hit her. These are things that we often hear. And then if you speak to the survivor to get the context around what's going on, you might then learn that that perpetrator came home in a really bad mood. There was a really tense atmosphere. Whatever that woman or survivor did, it didn't have a difference. She knew that it wasn't going to be a good day for her. That person ended up, the perpetrator, perhaps maybe there was an argument. They ended up throwing a remote or smashing a plate against the wall and then yelling at the person aggressively in their face. So you get a lot more detail of what actually happened. And that's the point of these programs, is to kind of unpick and get to the bottom of the context and get that person to recognize that the behaviors you're using are harmful, and to own up to that and to recognize the impact it's having, the effect it's having on that victim. So that's just hopefully it's useful to think of that telescope. What lens are you seeing this from? And we know that behavior change programs work. One of the most comprehensive studies that was undertaken is called Project Mirabel, and you can read the report online. But it shows that behavior change programs, they looked at 6 particular areas, including how it increased safety, how it impacted on the relationship quality, being respectful and supportive, how it looked at parenting, how it impacted on children, and how it improved the space for action for survivors. And there are positive outcomes identified for all of those areas. And the best way to measure the impact of these is to speak to survivors themselves. So it's important to get the view of the perpetrator, but most importantly, to find out, is that actually increasing the safety from the victim's perspective? So not only are we needing to provide behavior change programs, but we also need to do work in our communities with organizations and the just wider general public, because we know perpetrators will be there in all different domains of life. So one area that we've been looking at is that relationship with health and the huge connections that they have with survivors and perpetrators. And we were funded by Standing Together's Crossing Pathways project to deliver a 1-year project that looked at 3 hospital trusts across the country. So we have one in London, one in Nottinghamshire, and one in Northumbria. And Driti Suresh Epen is the domestic abuse and health lead working on this project, who is doing some great work with all of these 3 health trust sites. And all 3 identified that responding to perpetrators was a key priority for them. So Driti's been working to draft a policy framework that builds on what Sandy's important pioneering research shows us, that we do need to develop a response, and what that looks like in practice does need time to build and develop so that it's safe and effective. And these are the key components that we're drawing from the framework that we recognize as a starting point to developing a policy, for example, for responding to perpetrators as staff members. So what we've encouraged to do, sites to do in connection with us, is to look at what they're doing already to respond to survivors, because that's such an important foundation to build on. It really should be the starting point for developing any domestic abuse response. And then starting to look at any past HR cases, manager feedback, and investigations. So you can look at what went well, what were the lessons learned, where are the gaps, where do you need to develop as an organization, and start to identify lead roles. So rally the troops and bring people that are really interested in this work, that are across different departments and areas of the business, that can help to create a coalition, if you like, of support for this. And over time, hopefully that will build into potentially a champion network that you can then use across the organization. Looking then at your organization response and your policy. So what is your stance? Do you want to promote a culture of help seeking whilst taking disciplinary actions where it's become apparent that somebody has perpetrated abuse in a particularly harmful way? And how can you start to develop those policies from all of this information that you gathered? And then eventually, once you have those policies in place, where can you build this across the organization of the business? So including this in employment contracts, that the perpetration of abuse will be taken seriously, and looking at your handbooks and incorporating domestic abuse awareness and your stance into inductions. And then building capacity through training as well. So these are ways that you can actually increase space for action for survivors by creating a workplace that is safe and effective. So these are my contact details here at the Make a Change team, and also the contact details for Respect. And I've also put Driti's contact details there if you wanted to talk more about the exciting work that she's doing in health. Thank you very much for your time, and I will stop.
Thank you so much, Rebecca. That was absolutely fascinating. Really, really interesting. I'm going to hand straight over to Mina because we've started over time and she's a bit of a bad connection. Here, okay. Mina, over to you.
Thank you. I'm going to apologise in advance if I do lose connection. I'm having a really bad 45 minutes. I keep losing connections. So I don't need the slides. I'm just going to stop the slides there, and I'm just going to talk to you all about a new project that we've just launched in Leicester and Bradford about working with those using harmful behaviours. So my name is Mina. I'm the director of Hope, and I'm working in partnership with Sikh Women's Aid, a standalone South Asian victim survivor service based in Birmingham, but they do a lot of work nationally, and another South Asian service called the Halo Project. And the perpetrator intervention program that we're running is done in partnership with agencies called the Drive Partnership. So we're actually running a feasibility trial for those from South Asian communities that want to change their abusive behaviour. So we're running it in Leicester and in Bradford. If we go to the next slide. Or you can just remove the slides if that's easier. Or actually, I might be able to move the slides. Oh, there you go. Yeah. So we are running the project across Leicester and Bradford. And we have a number of domestic abuse perpetrator program facilitators that are based in both cities. We are currently recruiting participants onto the program. So if anyone has any staff or you have referrals coming into your organisation, as long as they're from a South Asian background, they are aged 18 and over, and they are looking to change their abusive behaviour, they can come into the service. I'm just going to see if I can go to the next slide. I don't think it's letting me move to the next slide. I don't know, Catherine, if you can move to this next slide. Yeah, brilliant. So what we do is we work with those who are classified standard to medium risk. And how we identify that is by using a risk assessment called a D-dash. So we ask the individual, once they contact us and they make a referral that they want to change their abusive behaviour, we ask them a series of questions and we do an assessment based on risk. And we think about the dynamics in their relationship. We also think about their motivation to want to attend. So the programme we run is 20 weeks. It's 2 hours and 10 minutes, runs 1 day a week for 20 weeks. And a lot of our work is also done around making sure the victim survivor is always kept safe. So whoever comes referred onto our programme, their partner, ex-partner or family member, depending on the dynamic of the relationship they're in, they can also get support. So what they will do is they'll get support from integrated support services, so our ISS workers, and they are workers from Sikh Women's Aid and the Halo Project. Currently, we are trialling a group which should start in June for Leicester and the same for Bradford, and that's face-to-face in the room. And we also offer one-to-ones. What we do know about perpetrator intervention, when you are working with those who want to change their abusive behaviour, in a group dynamic, sometimes it's better because you can see that peer interaction. It's always good to hear what other people are saying and to think about actually how do we challenge this. But we do offer one-to-ones for those that may not feel comfortable to kind of come to a group or may not want to do it in a group setting. And all of that is picked up in the assessment that we do with them. We are not Home Office or we're not Respect accredited, sorry, but we do adhere and work to the Home Office and Respect guidelines. Because we're a feasibility trial, we're in the really early stages of what we're doing. We go to the next slide. So for the victim survivor, they can be 16 plus. So we recognise that survivors may also be under the age of 16. So we're kind of working in guidance to the domestic abuse definition. The victim survivor can be from any background. We recognise that even though you might be from a South Asian community, you might be in a mixed heritage relationship. We offer one-to-one support with any victim survivors that come into the service, emotional supports, we give them updates about the programme, and we signpost them to other agencies. We go to the next slide. Okay, so if we go to the next slide, and what I'll do is I'll just give you an insight into kind of what our manual covers. So we have 4 phases. The first 6 sessions, so the first 6 weeks, when you get referred into the programme and you work with us, we do quite a lot around getting to know who you are. We also do quite a bit around understanding societal pressure. So what have you learnt around your behaviours when it comes to relationships? to thinking about your own thoughts, feelings, and behaviors, but also how do you communicate in a relationship? How do you communicate in a healthy way, in a way that is non-abusive towards your partner, ex-partner, or family member, but also non-abusive towards your children if you've got children in the home? We go to the next slide. And thank you for the feedback. I've just seen some feedback in the chat. The next phase, we are really focusing on the dynamics of what domestic abuse actually is. If you look at the statutory definition, that is all covered as part of the trial, but we also cover things like forced marriages, so-called honour-based abuse, faith-based abuse. We do quite a lot around immigration abuse. And we think about the power and control wheel and the equality wheel, and what does that mean when you are in a healthy relationship and you want to be in a healthy relationship. We've done quite a lot around stalking and tech-based abuse in our manual as well, and thinking about how you develop respect in that relationship and communicating in a respectful way when you're in that relationship. We go to the next slide. The next stage, we very much focus on you as a parent, or if you've got children, you may not have children. They might have nieces or nephews, they might have cousins, they might have, other young people that are kind of in that dynamic. So they don't have to be a parent, but we're talking about how it impacts children as well. We do quite a lot around generational differences and generational trauma and intergenerational violence and the impact this can have. We go to the next slide. And the last phase is very much about moving you on, making sure that you are held accountable for your behaviour if you're on the programme. How do you develop empathy and stay within that empathy of your relationship? We're really mindful, as someone who's worked with perpetrators now for 15 years and ran programmes with perpetrators of domestic abuse, I recognise a lot of people don't have a lot of empathetic behaviours towards their partners or ex-partners or their children. But also I recognise a lot of this is about the individual who's inflicting that level of harm, taking the responsibility, being held accountable, and thinking about, how do I better myself to ensure that I'm in a healthier and better sustainable relationship. The key of why we're doing this is to make sure that victims and children are always kept safe. And for those that want to change their abusive behaviour, they have the opportunity to change. Next slide, please. If anyone would like to get in touch with us about the trial, make a referral, or just speak to us about the work that we're doing, we are currently only trialling it in Leicester, Leicestershire, Rutland, and in Bradford at the moment, and it's running till April next year. Please just get in touch. We have a telephone number that's open Monday to Friday, 10 till 3. We have a generic email address that will also come through to myself as the project manager. And we do have a website, so please check it out. Thank you, Aisha.
Thank you so much, Mina. That's absolutely fantastic. And I believe there is a launch event coming up for one of the areas. So if anybody's interested or local to the area and would like to go, then we can either share some information in the chat bar, or please get in contact with Mina afterwards, who will share some details about it. I think it's next week. Thank you, Mina. Now coming to Emma. So Emma is from Lloyds Banking Group, who are an EIDA Beacon member and incredibly supportive of EIDA. They have some fantastic work in place for victim survivors who are employees, and she's going to talk a bit about why they want to do more work in the perpetrator space. So Emma, over to you.
Excellent, thank you. So we have set up our network in terms of supporting victim survivors of domestic abuse probably 4 or 5 years ago now. So we're in quite a level of maturity. So when we initially set this up, we created some training, which we rolled out across the organisation. And I've checked that we've currently got around 53,000 colleagues have completed that training as it stands today. We also put in place a raft of support. So some of that is around creating a space of safety for colleagues that are experiencing abuse and trying to find a way to manage that through, including support to look at how do I get access to housing, financial support, legal support, childcare support, and any other support that's required for them whilst they're during working hours. So as we're giving them a place of safety and a safe time to be able to explore this and look at ways that they might get themselves to a place of safety. We've also launched an emergency assistance programme for colleagues experiencing domestic abuse, which will give them up to 14 days accommodation, food, meals, laundry, telephone calls, all of that good stuff, again, to help them to plan and prepare for getting themselves to a place of safety. I guess we have reached relative maturity with all of that. It's very well utilised among our colleagues. The experience that we're giving as a result of that is proving very positive. But I guess we've reached a crossroads in that journey where we're very much cognizant that we need to do more. So looking at what do we do in that perpetrator space. And so reality is I'm here in very much full on listening mode, the same as many of you today, to understand exactly what we can do as an organisation to support perpetrators, but at the same time to ensure that we don't then degrade any of that great work that we've already done to support victim survivors, and to create a reasonable level of psychological safety to come forward when they do require support, as we have in the organisation today. I think other things that we're looking at the moment is peer support networks, again, for both perpetrators and victim survivors. So really keen to look in that space. So I guess purpose of me coming today is very much talking around as an employer, you know, some of the work that we have already done and how that now is leading into very much the perpetrator space. That's probably me in summary, Aisha.
Amazing. Thank you so much. That's really interesting. And it's great. I mean, Lloyd do some really great work. And, you know, it's just highlighting there the fact that the victim survivor response needs to be the foundation for thinking about how an organisation goes about addressing perpetrators. And as we've heard from the speakers today, it really needs to be survivor led. For employers, if a victim survivor and a perpetrator both work within the organisation, this is perhaps easier to do because you can speak with the victim survivor, find out what it is that they want to happen in that situation. For situations where they don't both work within the organisation, it's just the perpetrator that works there, this can be more challenging, but it's really, really great to hear about how the intervention programmes work, that they work with the victim survivor, they provide them with that support to make sure that it really is through that survivor lens. So really interesting session. So thank you all to the speakers. As anticipated, we don't have time for questions, but I'm sure you will all agree that the content was very insightful. So thank you to Sandy, Rebecca, Emma and Mina for sharing your expertise today. We will take the questions away and endeavour to answer them within the written summary, which will be circulated in due course. And please do subscribe to the newsletter if you don't already. The next Insight Hour will be on Tuesday, the 8th of July, and we'll be looking at how employers can support male employees impacted by domestic abuse. And we'll share more details shortly. I think there's going to be a link in the chat there to sign up. We are taking our in-person events to Newcastle. So we have an event on the 4th of June at Northumbria University in Newcastle, looking at why supporting families impacted by domestic abuse should be on every employer's agenda. So we'd really love to see you there. If you fancy a trip to Newcastle, or if you're in the local area, please do come in. We've got a link there again to sign up to that one. Just a quick reminder that we have our member survey out at the moment, so please do, if you're the member contact for the organisation, please do complete the survey. It closes on the 30th of May. If you don't have the link for that, let us know and we can send that on to you. Any topics that you're interested in hearing more about, please let us know and we can think about covering those for a future session. And thank you all for being with us today. It was really great to see so many on the call, and we look forward to seeing you soon.